Good evening. Tonight we're going to be doing some Ask Me Anything. Hopefully the audio is working well this time. I did a sound check beforehand and things were good. So there's a lot of good questions tonight. I actually typed them all up so that on the replay you can see what questions and what order we're going to answer them. So if you have questions that weren't submitted ahead of time, just drop them in the comments and we'll get to them at the end if there's time. Usually go for about half an hour. So welcome to those that are joining. We're going to be doing the Ask Me Anything tonight. First question up tonight, if blood pressure has always been on the low side, do I need to worry about heart health? So if the blood pressure is low and you're asymptomatic, meaning you're not dizzy, lightheaded, nearly passing out or passing out, then it's probably something not to be terribly concerned about. But heart health is all encompassing of cardiovascular disease, cardiomyopathy, high blood pressure. There's a lot of things that are in heart health, but low blood pressure is a good sign that you don't have high shear stress going across your artery walls. So maybe a little less risk developing atherosclerosis, but show me your arteries. So that's where the carotid intimal medial thickness test and the calcium score test and the CT angiograms can really tell you if your artery is truly healthy or not. Next question up tonight. What is the purpose of a stress test? The short answer is to evaluate for ischemia, which is lack of blood flow to the myocardium or the heart muscle. There's multiple different versions of stress tests. They will either require exercise, often on a treadmill, sometimes on a bike. When I was at the VA as a resident and a fellow, they actually had an arm crank, like you would just pedal with your arms. So that's the stressor. And then often they would add imaging, either ultrasound to your heart, which is an echocardiogram, or a stress test. A nuclear imaging component to it. So it's to assess for ischemia or lack of blood flow. Often you're not going to fail a stress test unless you have a 70% blockage in one of your arteries. And unfortunately, the majority of the heart attacks occur when the blockages are less than 50%. So you can pass a stress test and still have a heart attack. So stress tests are good if you're having symptoms, chest pain, shortness of breath, exercise intolerance, but they're not the greatest test to tell you are you at high risk or low risk of a heart attack. Question about high levels of Billy Rubin. Billy is considered as cardioprotective, yet it is from heme breakdown. So it sort of depends on what a high level Billy Rubin would be. If your Billy Rubin is less than 2, it's likely not a big issue. It may actually be Joubert syndrome, which is a genetic issue where you have slightly elevated levels of Billy Rubin, which is a antioxidant. So I'm not generally concerned that Billy Rubin is less than 2, but if you also have high transaminases, then you may be more concerned that there's a gallbladder issue with it. Or, like you said, you're having some issue with red blood cell breakdown. Next question up tonight. 67-year-old with a CT coronary calcium score of 1, but lipids are high. What could account for that? So you answered your question a little bit. Having atherosclerosis, is common at that age. A score of 1 is not necessarily high risk, but it's always going to be an ApoB containing lipoprotein that delivered that cholesterol to the arterial wall. The artery caused an inflammatory response to be had, and the plaque built up, the body scarred it, and it calcified. So you want to know what is your lipoprotein load. So mostly you look at apolipoprotein B. Once your calcium score is above 0, often you want to be less than the 20th percentile on ApoB. So an ApoB of 70 is probably your goal. And then, blood pressure less than 120 over 80, normal glucose response, and A1C of 5.1, insulin less than 8. Don't smoke, that'd be uncommon for most people these days, and be physically active. Those are the starting points. But you need to know about endothelial health as well, and I know I have some questions coming up about that, so we'll answer that in just a moment. There was a question that was submitted via DM to me about what are my opinions on microvascular disease. It's something I evaluate and treat every day of my practice at Apollo Cardiology. So you have arteries, coronary arteries that sit on the outside of your heart, kind of like my fingers would be. But the microvascular system is 99% of your blood vessels, and they're providing oxygen nutrients to the majority of the organs and tissues. So 60,000 miles of blood vessels, the greatest majority of them are the microvascular system. So similar concept, got to have a healthy glycocalyx and nitric oxide levels from the endothelium, low inflammation, low ApoB particle count, less likely to have microvascular disease. Next question is an electrophysiology question. So, person reports having a heart rate consistently averaging at 50 for the past 4 years. They report no symptoms. They're 73 years old. Do they need a pacemaker? Well, I can't offer direct medical advice in this platform, but generally, people who are asymptomatic do not need backup pacemakers. But you have to ask your questions to yourself, are you truly asymptomatic? So no episodes of being dizzy, near passing out or passing out, no exercise intolerance, meaning you can go up as many flights of stairs as you want without having to stop. Can you do regular exercise and not have to pause because you're short of breath or just can't get your heart rate up? So do you have chronotropic incompetence? Back to that previous question about stress tests, sometimes that is a reason for a stress test, is put somebody on a treadmill and walk them and see what could their peak heart rate be. If you can get your heart rate up with exercise, not as concerning. But if your heart rate's going to stay 60, 70, despite increasing exercise, then maybe a backup pacemaker might be utilized in that case. But generally, you have to be symptomatic before they're going to recommend pacemakers. Next question tonight. What can you test for and do to lower risk if you have a really high calcium score? This is a great question, and it's something we do every single day at my practice. So a CT coronary calcium scan should ideally be 0. A score over 400 is considered high risk. Over 1,000 is very high risk. A couple of patients this year I've seen over 3,000. Highest score I've seen 7,700 something. But often the calcium is in the walls of the artery, much like an iceberg. The plaque is building up under the surface of the ocean, and only a little bit pokes up above the ocean's surface and occludes the lumen where the blood is flowing. So high calcium score test does not necessarily mean that you're going to be symptomatic, but the high calcium also tends to come with a lot of salt plaque, and that's what you're concerned about, is treating the salt plaque. So how do you test for it? Well, non-invasively, you can look at your endothelial function with tests like the EndoPAT. The Max Pulse device looks at pulse wave velocity or arterial elasticity. How springy are your arteries? Carotid intimal medial thickness ultrasounds can test for vascular thickness, inflammation in the artery wall, salt plaque in the carotid, 80% correlated with what goes on in the carotid, what's going on in your coronary arteries. Then there are tests that can look at your biomarkers that would give you higher risk. So all the inflammatory markers, high sensitivity CRP, myeloperoxidase, LPPL2, some of the ones off the top of my head, the markers of nitric oxide availability, ADMA, STMA, urine microalbumin creatinine, then the lipoproteins, mostly ApoB containing particles. So a comprehensive blood work panel and some non-invasive testing can really tell you what's driving that high-risk calcium score test. Often genetics are involved, and we can do that as well if you're working with us. But there's a lot of things to be done. First, find it, and then help stabilize it. This is a really good question coming up. So my opinion on statins and brain fog / cognition. So this is something that, if you go into Dr. Google, you're going to see a lot of. But clinically, in the 20 years that I've been practicing as a physician, I've not seen it very often. Now, your brain makes its own supply of cholesterol. So it's not waiting on a lipoprotein made in the liver to deliver cholesterol to it. That's the location that statins are mainly working. But statins can get across the blood-brain barrier and cause brain fog or cognition. Tends to be more with medications like atorvastatin, the fat-soluble statins, but the water-soluble ones can do it as well. People who tend to be a little bit more sensitive to it are the people who are ApoE4 carriers. And there's a test you can look at called the cholesterol balance test on the Boston Heart Lab panel that looks at desmosterol levels. If your desmosterol levels less than the 20th percentile and you're on a statin, you probably want to back off on the dose of the statin. You're a little bit more at risk of having those complications. So it's one of those test don't guess, type of philosophies, or show me the data. From Missouri, you need to show me a lot of times. So the blood test can kind of tell you, are you likely to have a side effect like that? But sometimes that's the reason people can't tolerate statins. So then you just got to go do plan B, and we'll talk about some of the plan Bs coming up. And maybe I'll just do this one here because it ties into it. Is it safe to take a statin for bodybuilders? The short answer is yes. And the longer answer is that bodybuilders, depending on what level of bodybuilding, they're often at higher cardiovascular risk because they often have a lot of unmitigated cardiovascular risk factors. Just because they're very fit on the outside doesn't mean their arteries are very healthy. A lot of them have a lot of chronic inflammation from overtraining. And some of them are doing exogenous compounds that put a lot of stress on the cardiovascular system. So statins are just tools. Sometimes these tools are used in these patients, but you want to match it to the person's lipoproteins. If they have high ApoB greater than 20 percentile, then possibly, especially if they're a hyperproducer of sterols. But if they can't tolerate statins because of muscle symptoms, or that's the main concern, and they're just like, I'm just not going to take it because I'm concerned about muscle symptoms, then you could consider something like bempedoic acid, which is Nexletol. That works in the liver, blocking cholesterol production. You can have a PCSK9 inhibitor. There's 3 on the market right now. There's Repatha, Praluent, and Elisclerin. Elisclerin's twice a year injection. And then there's the cholesterol reabsorption inhibitors. That's ezetimibe. So there's at least 5 other agents that are possibly useful in patients that are statin intolerant, or just for whatever reason, I like not to go on statins, but you want to treat your ApoB to the appropriate goals. Next question up tonight. Do you need aspirin if you take vitamin E and nattokinase? So again, I can't offer direct medical advice and tell you, what to take or not to take, but in all comers, for the most part, it's rarely needed that you take aspirin and nattokinase. The main reason you use nattokinase is you have high fibrinogen levels. If you have high fibrinogen, your blood, that's why I tell patients, more likely to be ketchup, blood's more sticky, and nattokinase breaks up that fibrinogen. Aspirin prevents the platelets from aggregating in those fibrin clots as well. Vitamin E by itself is not typically that useful. In many trials, they show that if you take vitamin E by itself, people tend to do worse. So vitamin E is in your fruits or vegetables, fine, but I don't personally recommend a lot of standalone vitamin E supplementation. Next question up tonight. How is diabetes related to cardiovascular health? Well, it's one of the major cardiovascular risk factors. There may be nearly 400 risk factors that damage the cardiovascular system. High blood pressure, high blood sugar, high lipoproteins, or quote cholesterol, smoking, and obesity to be in the top 5, but there's at least 395 other ones. But diabetes, is one of the main things that damages the glycocalyx, which is the protective sugar coating lining the 60,000 miles of blood vessels you have. So uncontrolled blood sugars and high insulins damage that protective coating. Then the lipoproteins are more likely to adhere to the endothelial surface and get retained in the intima. There's different antioxidants housed in the glycocalyx. There's different clotting factors housed in the glycocalyx. So high diabetes loads, or high blood sugar loads I should say, damage that coating and then kicks off this cascade. So you want to do everything possible to reverse diabetes. Yes, always start with lifestyle interventions. So resistance training, zone 2 training, appropriate carbohydrate loads. Carbohydrates, depend a little bit on your physical activity, but 130 grams is around the usually recommended upper limit for most people, unless they're doing a lot more physical activity. You can use a continuous glucose monitor to figure out if you can kind of play around with that kind of meal threshold, but controlling what you can control. And then often, if you have normal renal function, then starting metformin soon to try to help with some of that glucose sensitivity. But diabetes is one of the things that you want to aggressively manage because it's one of the things that will drive worsening cardiovascular disease, kidney failure, stroke, heart failure. So person's asking how to reduce LDL, trig, and HDL good. So I'll answer the second part first. just because your triglycerides and HDL are, quote, good, doesn't mean that the LDL is not a problem. It may mean that you're not insulin resistant, but LDL-C, which is measured on the cholesterol panel, is not as predictive as the LDL particles or the ApoB containing particles. So if your LDL-C is north of 100 milligrams per deciliter, you still may want to lower it if you have atherosclerosis. So high plaque burden on your CT coronary calcium score or a CT angiogram or abnormal carotid scan would still likely indicate that you'd want to have lower LDL cholesterol. And that would be through either statins, bempedoic acid, PCSK9 inhibitors, or ezetimibe, the pharmaceutical route, berberine, bergamot, are generally the better kind of supplements sometimes to do that. But always start with lifestyle. It always starts with exercise and monitoring your saturated fat intake. So if you're doing a high-fat keto diet or a kind of dirty carnivore diet with high saturated fat, sometimes cutting back on the amount of saturated fat you're eating, probably less than 10, maybe 8% of your calories from saturated fat may improve your LDL cholesterol as well. And next question up, Arterosil versus Arterial Protect by Life Extension, which one is more beneficial? Hard to really head-to-head comparison them because they are working on different aspects of atherosclerosis. So Arterosil is a glycocalyx promoter that helps regrow that protective gel coat in your 60,000 miles of blood vessels, tries to prevent the damage from occurring in the first place, where Arterial Protect is more about the plaque is present and you're trying to stabilize the plaque. You're trying to take the plaque from something that is soft and vulnerable and trying to shrink that plaque down. Arterosil has some benefits of doing that as well for some of the soft plaques in the carotid. I'm sure they're going to be evaluating things in the coronaries eventually, but they're not apples to apples comparison products. So generally it'd be both if you have access to both. If you're going to take one or the other, well, it would depend on what's going on with your endothelium and your blood pressure. That would lean towards maybe more Arterosil. If you have a lot of soft plaque that's found on the CT angiogram or carotid scan, maybe the Arterial Protect, but generally both. All right, so I think I got through the questions that were answered or asked ahead of time. Thank you guys as always for the great questions. I will put these into my story as well as in my main feed, and I'll have the questions answered for those that joined a few minutes late so you can see what we're answering tonight. All right. So I'd have to see the actual study you're mentioning, but somebody's asking, how do I feel about the study that showed the population with the highest cholesterol lived the longest? So there's always going to be people that live, 100 years with, quote, abnormal cholesterol and they smoked and drank and didn't exercise, but that's the exception to the rule. Atherosclerosis tracks with the lipoprotein burden, the ApoB containing particles. So I sometimes get that question too, is the lowest ones had the worst outcomes. Well, those people are very sick. People with cancer have low cholesterol levels. People who are sarcopenic have low cholesterol levels. It's not people who are healthy and vibrant who are on lipid-lowering therapies that are decreasing their health span and longevity with it. So I'd have to see the exact study. So if you have a link to it, just send it to me in a DM, and I'll try to take a look at it. Person is asking, their mother has calcifications of the aorta and plaque in her arteries. Of course, the doctor does not tell her to, I think it's do or do something about a low carb diet. In Costa Rica, we eat rice 3 times a day. I keep telling her. So, aortic calcifications, is often a sign of dyslipidemia damaging it, but sometimes it's due to lipoprotein a, which is a very atherogenic and calcifying type of particle. Up to 20% of the population has it. So if you have calcifications of the aorta, Yeah, I'm sure you don't have calcifications of the aortic valve. That's what I'd be concerned about. But a low-carb diet, it really depends. That's why this form is always so challenging to kind of give nutrition advice, because it depends on your maternal haplotype. Where is your original mitochondria from? Where do you live in the world right now? What season is it? What is available to you if you walked outside your door? That is the kind of diet that you would start playing around with. But you got to have high quality protein to help your body maintain your muscle mass. And then you figure out, are you in a weight reduction strategy, maintain, or weight gain strategy? And then you can kind of play around with the carbs and the fats to get those goals. So somebody's saying that they think cholesterol medicine is a poison. That's your opinion. I mean, I don't tell people they have to do anything. It's, you always decide what goes in your body: food, light, energy, medications, supplements. But, you can't deny what drives atherosclerosis. There's always an ApoB-containing particle involved in the process. There's an inflammatory response. There's endothelial dysfunction. If you don't test your arteries, you don't test your biomarkers, how do you know where you're at if your cholesterol is good and normal? So if your decision is not to take a prescription medication, how are you going to lower your ApoB to the 20th percentile? So I work with my patients all the time on coming up with those strategies. So I may disagree with the thing that medications are always poison. They're tools to be used when you need them. So somebody's asking, what type of heart conditions can you find with a stress test? Generally, you're doing stress tests for ischemia. You can also do it for chronotropic competence. There was a question earlier about somebody with a low resting heart rate in the 50s. So you can see does the heart rate pick up. You can do them to see, can you induce arrhythmias or suppress arrhythmias, abnormal heart rhythms? Those are probably the most common reasons. And sometimes there's work physicals, firefighters, pilots, they require them as part of their jobs. So those are the main reasons you would do one. All right, question. I've been on a whole food, nearly vegan diet, but feel poorly. Low energy, eating plant-based proteins, but still feeling exhausted. Need to add animal protein back. How to, without increasing cholesterol? It's a great question, and it just shows you that there is no perfect diet. So if there's anybody online telling you like everybody has to eat a certain way to be healthy, they're trying to sell you something, some supplement, some book. I have nothing to sell you. This is just me giving back, answering questions because I like to educate. But you're your own kind of N of one. If you don't do well on that diet, you then have to figure out what macronutrients do make you feel better. But typically the cholesterol issue is more with the saturated fat that comes back with some of those animal proteins. So if you typically stay on a lower saturated fat diet for that, you probably feel a little bit better. But not everybody's so sensitive to saturated fats. So, so there are people that can eat very high levels of saturated fat and not have significant dyslipidemia. So it's test, don't guess type of thing. So get a baseline level of labs, change up what you're going to do from a diet standpoint, and then recheck and see where things are at. But base it off also how you feel. If you have more energy, brain's working the way you want, exercise is better, sleep is better, then you know you're on the right track. So somebody's asking, can you lower your LDL too much? Generally, no. There are people who have LDL cholesterols that are undetectable in certain labs. I told the story before, but I have a great-grandmother who was born in 1893. She passed away in 2000. I met her, and she was 106 when she passed. She did not see doctors, did not take medications, didn't do any of this lifestyle stuff that we're talking about tonight. And she very much had low LDL her entire life. I know that because I tested some of the genetics of her relatives and found that they had a loss of function PCSK9 gene. PCSK9 is an enzyme that degrades the LDL receptor. The LDL receptor sits on the outside of the liver and grabs the lipoproteins that come by, kind of like a cargo docking station. If you don't have that cargo docking station, those lipoproteins are just circulating around through the vascular system, and more of them may be interacting with the arterial wall. It's like shots on goal. More shots, more likely some of them get retained in the artery wall. So I have family members whose LDL cholesterols are in the 30s and 40s, and they're doing very well. So the LDL cholesterol, that you're monitoring in your blood is not the amount of cholesterol that you have in your body. It's less than 5% of all the cholesterol that you have in your body. So generally the answer is no, especially if you have atherosclerosis. Now for primary prevention, maybe you're not trying to drive your LDL cholesterol down to 20, 30, but that's typically about the cholesterol that a newborn has is an LDL cholesterol, or an ApoB actually, like in the 20s to 40s. So no, generally lowering to LDL too low is not a concern. Now in the moments of like sepsis and shock, yes, having low cholesterol, you wouldn't test your cholesterol in this instance. You're dumping all hands on deck. Cholesterol is going to your adrenals to pump out more cortisol and such. But using pharmacological, nutraceutical, lifestyle interventions to lower LDL generally is not going to be an issue. So somebody's saying they're struggling to balance the need to lower cholesterol with getting proper nutrition. I would simplify it. Focus on getting the proper nutrition and then seeing what you got left over. If your lipoproteins aren't at the goal that you and your doctor feel comfortable with, figure out what nutraceutical or pharmaceutical agents you're comfortable with and lower the ApoB with that. That's often something that some patients find luck with. Some people do feel outstanding on a keto diet and they're not willing to change it. Some people think a carnivore diet works really well for them. Okay, just treat your lipoproteins after you get the nutrition dialed in. All right, this is a good question, but doesn't have a direct answer. But which type of sauna has the most cardiovascular benefits, Finnish or infrared? The most data is definitely by far on the Finnish saunas, and typically it's 4 sessions a week for 20 minutes, temperature 179 degrees Fahrenheit is what I've seen. But I usually tell people, like, you want 20 minutes of just a rolling sweat, whatever temperature that is to get you there. As for the infrared saunas, I've had 2 different ones. I enjoyed them both. But it's the near, mid, and far wavelengths that are beneficial. So it's not that the far is necessarily better than near. The far will induce more sweating, so that is beneficial for pulling out heavy metals and toxins. But there's still benefits of the near infrared for improving the exclusion zone water in your cells. So both wavelengths are beneficial. So I don't know what in context this is, but what's better, a cardiac MRI or CT? Depends on what you're looking for. Cardiac MRI is generally better at looking at the myocardium or the heart muscle and the valves, where CT is better looking at the coronary arteries. So that's how I kind of differentiate that. It's not that common to get a cardiac MRI unless you have a cardiac, which is like an infiltrative cardiomyopathy or something going on with your right ventricle. They may do a cardiac MRI, or if they're concerned about myocarditis, they would do an MRI. All right. Well, I think I got through all your guys' questions tonight. I usually try to keep it for half an hour because the new format is every Monday, 6 p.m. Central Time. We're going to be doing these Ask Me Anythings. I've been doing this for the past 6 weeks. Previously I was doing some long forms, talk about particular topics. We may go back to doing that in the future. I'll probably put a poll in my story sometime, and you guys can vote, and whatever gets upvoted to the most, then we'll do like a standalone, 15, 20-minute chat about. If you want to hear me do one of those topics before I put up the poll, you can always send me a direct message or add it to the comments to this story. I appreciate your guys' time and attention. Thank you very much for asking great questions, and have a great week.